Welcome to the deep dive. We're here to take complex, really dense information and break it down meticulously into the key insights you need. Today, we're plunging right into the very core of what makes us tick, but also, what can go terrifyingly wrong. We're talking about the intricate electrical system of the human heart. Our mission, our goal for this deep dive is to really unpack Chapter 255 of Harrison, which, as you probably know, is one of the most respected medical textbooks out there. We're aiming to go beyond just reciting facts. We want to master this information, understand it like true professionals. So you walk away feeling genuinely well informed, ready to grasp the nuances of these cardiac arrhythmias. Yeah, the source material we have is incredibly rich. It's this detailed chapter from a top-tier medical textbook. We've gone through it meticulously, dissecting every concept, every little detail. And this deep dive, it's designed to pull out all those crucial nuggets of knowledge, giving you, hopefully, an elite-level understanding. Think of it as a shortcut to really mastering these complex, often life-threatening conditions.
Indeed. And we're about to embark on, really, an exploration of the nuanced differences and, importantly, the critical connections between two very significant cardiac conditions, polymorphic ventricular tachycardia and ventricular fibrillation. Understanding these details, it isn't just about memorizing terms. It's truly paramount for genuine clinical insight, for recognizing danger signs, and ultimately for saving lives. We're going to dive deep into the why behind these conditions, the subtle distinctions that set them apart, and of course, the cutting-edge approaches to managing them.
Okay, great. Let's unpack this then, starting with our first major topic, polymorphic ventricular tachycardia, often just called PVT. Now, for anyone who's seen an ECG strip, this can look, well, pretty dramatic. What exactly defines it on that electrical tracing, and what's happening inside the heart to create that visual chaos?
Right. So a key insight into polymorphic ventricular tachycardia, or PVT, is right there in its name, polymorphic. It refers to its continuously changing QRS configuration. From beat to beat on an electrocardiogram, it's different. Unlike a nice steady rhythm, or even its more, let's say, organized cousin, monomorphic VT, PVT shows this wildly fluctuating waveform.
Wildly fluctuating.
Yeah, it's not just a subtle variation. It vividly indicates a constantly shifting ventricular activation sequence. Think of it like maybe a chaotic, uncoordinated dance where the steps are just never the same. And crucially, this dynamic, ever-changing pattern often suggests that the electrical disturbance isn't originating from a single fixed spot or, a rigid structural abnormality in the heart like you might see in monomorphic VT. Instead, it points towards a more widespread, fluid, and unstable electrical environment within the ventricles. The source of the electrical misfires is continuously changing its location or its pathway, which really begs the question, doesn't it? What kind of underlying mechanisms could cause such a dynamic and, frankly, unpredictable electrical storm?
So, given that constantly shifting ECG, we're talking about mechanisms that are equally fluid then, right? Not some single stubborn spot causing all the trouble, but something far more dynamic, harder to pin down.
Precisely. Exactly. The mechanisms often involve what we call dynamic reentry.
Dynamic reentry.
Yeah, where the electrical signal loops back on itself. But instead of following one fixed, predictable track, the reentrant electrical paths are continually shifting and changing within the heart muscle. Imagine like a racing car on a track, but the track itself is constantly rearranging its turns.
Okay, wow.
Another related mechanism is spiral wave reentry. This is a highly unstable, very complex electrical phenomenon where the electrical wavefronts kind of spiral outwards, continuously breaking and reforming, creating this widespread disorganization. Now, these chaotic patterns, they can occur near fibrotic areas of the myocardium, so regions of scar tissue in the heart muscle that disrupt the normal electrical flow.
Right, the scar tissue gets in the way.
Exactly. And it's notably potentiated, or made worse, by proximity to damaged Purkinje cells, those specialized electrical wires of the heart that conduct impulses really rapidly, or by ventricular hypertrophy, which is that thickening of the heart muscle. This really highlights how susceptible the heart's electrical pathways are to even microstructural changes in cellular damage. It makes them incredibly ripe for these chaotic electrical storms. The very architecture of the heart, when it's disrupted, can become a breeding ground for these unpredictable arrhythmias.
And where does repolarization fit into this complex picture? That sounds like a really key concept. Tying into the heart's ability to reset its electrical charge after each beat seems critical for keeping rhythm.
Repolarization is indeed a profoundly key concept. It represents the electrical recovery of the heart muscle cells after they've contracted. Now, when we talk about abnormal transmural dispersion of repolarization,
Okay, that's a mouthful.
it is. It basically refers to inconsistencies in how quickly different layers of the heart muscle, from the inner to the outer wall, repolarize or electrically recharge after each beat. If these timing differences become too great, it's like setting the stage for an electrical short circuit or a dangerous misfire.
I see.
An early unwanted beat can find parts of the heart still vulnerable, still susceptible to re-excitation, even as other parts have fully recovered. This electrical instability is particularly relevant in the setting of channelopathies, which, as we've touched on, are genetic disorders affecting those crucial ion channels responsible for the heart's precise electrical activity.
Right, the genetic component.
Yes. But it can also be paradoxically triggered by certain antiarrhythmic drugs, ironically, drugs meant to treat arrhythmias or even occur in the apparent absence of obvious structural heart disease. The critical take-home here, though, is that sustained polymorphic VT is rarely benign. It has a very serious consequence. It tends to degenerate into ventricular fibrillation. And as you can imagine, ventricular fibrillation is a far more immediate and profoundly life-threatening condition. We'll definitely delve into that in extensive detail later on.
So understanding these complex mechanisms, what are the most common conditions or, underlying issues that we see associated with PVT? What are the usual suspects that clinical professionals are looking for when they encounter this chaotic rhythm?
Well, in the broader context of clinical practice, PVT is typically seen in close association with acute myocardial infarction or acute MI, which is, a heart attack, a critical lack of blood flow injuring the heart muscle. That's a common and urgent scenario.
Right, very common.
We also frequently encounter PVT alongside ventricular hypertrophy, that thickening of the heart muscle that can alter electrical conduction. And crucially, it's increasingly linked to a number of genetic mutations that affect the cardiac ion channels responsible for the heart's precise electrical activity. This highlights a significant genetic predisposition in some cases. These aren't isolated conditions. They really create an environment where PVT is just far more likely to occur.
Yeah. Let's zoom in specifically on acute myocardial infarction, or ischemia then. The source material really emphasizes this as a common and critically urgent cause, something that should be an initial consideration in an emergency. Why is this connection so immediate and dangerous in those moments right after a heart attack?
Well, the immediate danger of an acute MI lies in its profound electrical instability. It's quite startling. Actually, approximately 10% of patients experiencing an acute MI will develop ventricular tachycardia, VT, that then rapidly degenerates into ventricular fibrillation, VF.
10%? Wow.
Yes, and the risk, importantly, is at its absolute peak in that crucial first hour following the onset of the myocardial infarction.
A golden hour.
Often called the golden hour for intervention, yes, but also the most perilous for arrhythmias. The underlying mechanism is frequently re-entry through the infarct border zone.
That delicate area.
Exactly. That electrically unstable area bordering the healthy heart tissue and the newly damaged ischemic tissue. This border zone becomes a prime substrate for chaotic electrical circuits to form and propagate. More rarely, surviving Purkinje cells, part of that specialized electrical conduction system, can gain abnormal automaticity after the MI insult.
So they survive, but they're irritable.
Precisely.
Yeah.
Even though they survive, they become irritable and can spontaneously initiate PVT, essentially firing off disorganized impulses. They're trying to compensate maybe for the damaged tissue, but their efforts are uncoordinated and dangerous.
So if this chaotic and life-threatening arrhythmia occurs during an acute MI, what's the immediate action plan? Following the established emergency guidelines, what do medical teams do right away?
Right. The management of PVT in the setting of an acute MI rigorously follows the Advanced Cardiac Life Support, or ACLS, guidelines. This means prompt defibrillation is not just recommended, it's absolutely required. You have to reset that chaotic ventricular activity and restore a more normal, organized rhythm.
Got it. Defibrillation first.
Absolutely. Beyond that immediate life-saving intervention, the ongoing management really parallels the management for the acute MI itself. So this includes administering adrenergic blockers, beta blockers, which help slow the heart rate, reduce oxygen demand, and dampen that sympathetic overactivity.
Okay.
It also involves meticulously correcting any electrolyte abnormalities, imbalances in potassium or calcium, which are absolutely crucial for stable heart rhythm and often get thrown off during an MI.
Right. Those electrolytes are key.
They are. And most critically, the goal is to achieve prompt myocardial reperfusion, restoring blood flow to the heart muscle as quickly as possible, often through angioplasty or thrombolytic drugs. Which brings up an important question. If episodes of PVT keep happening, despite these initial interventions, What specific message does that send?
It sounds like repeated episodes would strongly suggest the core problem, the lack of blood flow, isn't fully resolved, even after the first attempts. Is that right?
Exactly. Yeah, repeated episodes of polymorphic VT are a stark warning sign. They strongly suggest ongoing myocardial ischemia. There's still a critical, unresolved lack of blood flow. This immediately warrants an urgent assessment of the adequacy of myocardial reperfusion. You have to ensure the initial interventions actually worked.
Makes sense.
And in the broader picture of patient outcomes, it's important to note that PVT and VF occurring within the first 48 hours of an acute MI are, unfortunately, associated with greater in-hospital mortality. It highlights the extreme vulnerability then.
Right, those first 2 days are critical.
They really are. However, here's a crucial and somewhat reassuring distinction. Patients who survive past hospital discharge from an acute MI, even if they had these early arrhythmias, are actually not at an increased risk for arrhythmic sudden death long term.
Oh, that's interesting.
It is. It suggests that the initial 48-hour window is indeed the most critical period for these specific arrhythmias. Surviving that acute phase dramatically improves the long-term prognosis regarding arrhythmia-related sudden death.
That's a huge relief then for those who survive that initial critical period. It really shifts the long-term outlook significantly. So what about long-term therapy for ventricular arrhythmia after an infarct? Does everyone who has an MI, especially with these arrhythmias, end up needing, say, an implantable cardioverter-defibrillator, an ICD?
No, long-term therapy for ventricular arrhythmias post-MI isn't a one-size-fits-all approach. It's primarily determined by the patient's residual left ventricular function, how well the heart pumps afterward.
Okay.
Specifically, an implantable cardioverter-defibrillator, or ICD, is indicated for patients with persistent, severe left ventricular dysfunction. And this is quantitatively defined as an ejection fraction. That's the percentage of blood pumped out of the left ventricle with each beat below 35%.
Below 35%.
Right. This device, it's essentially a small computer with a battery and wires implanted under the skin. It continuously monitors the heart's rhythm. If it detects a dangerous arrhythmia like VT or VF, it can deliver an electrical shock to reset the heart back into a normal rhythm. It acts as a crucial life-saving safeguard for those at the highest risk of sudden cardiac death.
Like an internal emergency system.
Exactly. But the decision to implant an ICD is a significant one, balancing the life-saving benefits with, potential discomfort and the psychological impact of living with the device.
Right, of course. Okay, let's unpack this next major section. Repolarization abnormalities and genetic arrhythmia syndromes. This sounds like where things get really intricate. We're delving into conditions where the heart's electrical wiring is sort of predisposed to go awry. Starting with acquired long QT syndrome, what are the key warning signs? How might someone with this condition present clinically?
Right. Patients with acquired long QT syndrome typically present with a spectrum of symptoms. It can range from near syncope, that alarming feeling like they might faint.
That dizzy, lightheaded feeling.
Exactly. To actual syncope, a full loss of consciousness, or even tragically full cardiac arrest. What's profoundly concerning is that sustained episodes, if they're not treated immediately, frequently degenerate into ventricular fibrillation, requiring prompt defibrillation to save their life. And a noteworthy clinical observation is how often we see premature ventricular contractions, PVCs, those early extra beats from the ventricles, when non-sustained VT episodes preceding these sustained life-threatening events.
Like warning shots.
Kind of. They often act as a sign of electrical instability, a warning that the heart is in a precarious electrical state.
And the mechanism behind this specific type of PVT is described as pause-dependent. That sounds quite specific. The source material even points to figure 255-1. Can you walk us through what that means? How does that pause play such a critical role?
Yes. The classic initiation sequence for torsades de pointe polymorphic VT, which is a specific type of PVT seen in long QT syndrome, is indeed called pause-dependent. As figure 255-1 illustrates quite well, it typically begins with a normally conducted sinus beat from the heart's natural pacemaker. This is then followed by a premature ventricular contraction, a PVC, an early beat from the ventricles, occurring before the heart has fully recovered electrically. This KVC is crucial because it's usually followed by what's called a compensatory pause, basically a longer than normal interval before the next regular sinus beat arrives. That longer gap, the pause, that's the one. This longer RR interval, this pause, is the critical element. It allows for increased dispersion of repolarization, meaning different parts of the heart muscle recharge at slightly different speeds, creating vulnerability. Then, a subsequent PVC, occurring after that next sinus beat, effectively interrupts the T wave. the part of the ECG representing repolarization or electrical recovery. This early beat landing on a vulnerable, partially repolarized T wave, often called the R-on-T phenomenon, is the spark that ignites the chaotic polymorphic VT.
R-on-T.
Yes, it's that precise, long-short interval sequence, a pause followed by an early beat that is characteristic and allows this dangerous rhythm to take hold. It's like a perfect storm, electrically speaking.
So what causes this critical QT prolongation that sets the stage for all this? I understand there's a surprisingly long and diverse list of factors, not just one medication. Must be challenging to track down the cause sometimes.
Oh, absolutely. The diversity of triggers for acquired QT prolongation is truly a critical point, and it does raise an important clinical challenge. The causes include critical electrolyte abnormalities, notably hypokalemia, which is low potassium,
Yeah.
and hypocalcemia, low calcium. Both are vital for proper electrical signaling in the heart. Bradycardia, a slow heart rate, can also lengthen repolarization time, making the heart more vulnerable. But a particularly striking aspect is the extensive list of medications that can block repolarizing potassium currents, specifically the IKR current, leading to a prolonged QT interval.
And it's not just heart drugs.
Not at all. That's the key. It includes antiarrhythmic drugs like sotalol, dofetilide, and ibutylide, which are used to treat arrhythmias but can, ironically, cause this dangerous side effect. But what's particularly concerning for clinicians is that it also encompasses many other medications used for completely non-cardiac diseases, drugs that might seem totally unrelated.
Like what?
Common antibiotics like erythromycin, the antiparasitic pentamidine, even antipsychotics like haloperidol and phenothiazines, and opioids like methadone.
Wow, everyday drugs, potentially.
Potentially, yes. This broad spectrum means that a careful, comprehensive medication review is always critical for any patient presenting with symptoms suggesting long QT. And furthermore, individual susceptibility can also be influenced by genetic polymorphisms. Some people are simply more predisposed due to their unique genetic makeup, even without a full congenital syndrome.
That's an incredible amount to keep track of, really underscores the complexity of medication interactions and individual responses. The source even points to a specific resource, crediblemeds.org. That must be invaluable for clinicians.
Absolutely. The website crediblemeds.org is an excellent, dynamic, constantly updated resource. It's a critical tool for clinicians to quickly check if a given medication, or often more importantly, a combination of medications, is known to prolong the QT interval or interact dangerously. It allows for proactive medication management, helping prevent these arrhythmias in the first place. It's crucial for patient safety, a great example of digital tools helping clinical decisions.
So, if someone is experiencing an acute episode of acquired long QT, maybe with torsades de pointe, how is it typically managed right then and there? What's the immediate treatment strategy?
Okay, the acute management of torsades de pointe, due to acquired long QT syndrome, focuses on immediately stabilizing the heart and addressing the underlying cause. Intravenous administration of 1 to 2 grams of magnesium sulfate is usually the first line, and it's often remarkably effective in suppressing recurrent episodes, even in patients with normal magnesium levels.
Magnesium, interesting.
Yeah, the exact mechanism isn't fully clear, but it's thought to affect calcium influx. If magnesium alone isn't enough, the next crucial step is to increase the heart rate.
Speed it up. Why?
It helps shorten the QT interval, reducing that vulnerability window. This can be done either with an intravenous isoproterenol infusion, that's a beta agonist that speeds up the heart, or through temporary transvenous cardiac pacing. The goal is a heart rate of around 100 to 120 depolarizations per minute.
Okay, faster to stabilize.
Exactly. These acute maneuvers, they buy crucial time. They allow the medical team to identify and correct the underlying issues like electrolyte disturbances or bradycardia, and, most importantly, to remove any causative drugs prolonging the QT. And it's vital to remember that drug interactions elevating the levels of the offending agent are often a precipitating factor. So a thorough medication history is paramount.
And for long-term management after such an acute event, strict avoidance seems like the obvious answer.
Precisely. Patients who experience polymorphic VT induced by QT prolongation should be considered to have a fundamental susceptibility to this arrhythmia. It's not just a one-off thing. Therefore, they must strictly avoid all future exposure to any medications known to prolong the QT interval. This isn't just a suggestion, it's a critical safety measure, really a lifelong commitment to prevent recurrences. Requires careful patient education and vigilance from all their healthcare providers.
Now, let's unpack that detailed table 255-1 from the source, listing the comprehensive causes of acquired QT prolongation. This seems vital for understanding the full scope, going beyond just the common ones. It really opens your eyes.
Yes, this table is an excellent reference, and it truly highlights the sheer breadth of factors involved. It underscores the systemic nature of this vulnerability. It details not only drug-induced causes, but also cardiac, endocrine, intracranial, and even nutritional disorders. It's a real testament to how interconnected the body is. So the table starts by mentioning the congenital long QT syndromes themselves, LQTS, because these genetic predispositions can interact with acquired factors. It specifically notes types 1, 2, and 3 are due to mutations in specific genes. KCNQ1, KCNH2, SCN5A, affecting key potassium or sodium channels. And these three types account for, 80–90% of congenital cases.
The main genetic players.
Right. Then electrolyte abnormalities. Critical, as we mentioned, hypokalemia, low potassium, hypomagnesemia, low magnesium, and hypocalcemia, low calcium. These directly impact the ion flow needed for repolarization. Any imbalance can destabilize things quickly.
Okay.
Then, the really vast category. Drug-induced acquired prolongation of the QT interval. This is where vigilance is so key. First, antiarrhythmic drugs themselves, both class IA, like quinidine, disopyramide, procainamide, and class 3, like sotalol, dronedarone, ranelazine, amiodarone, abutylide, dofetilide, designed to affect rhythm but can have this critical side effect, proarrhythmia.
The drug causing the problem it's meant to fix.
Exactly. Then a surprisingly broad range of antibiotics, macrolides like erythromycin, clarithromycin, azithromycin, fluoroquinolones like levofloxacin and moxifloxacin, even trimethoprim sulfamethoxazole, clindamycin, pentamidine, chloroquine, also antifungals like ketoconazole or triconazole, even the antiviral amantadine. It really highlights the need for careful review, even with common antibiotics.
Wow.
Then antipsychotics, haloperidol, phenothiazines, thiordazine, trifluoperazine, certain dolazomeladine, ciprasidone, also many tricyclic and tetracyclic antidepressants, even some common antihistamines, specifically H1 receptor antagonists like astimazole, diphenhydramine, hydroxyzines. That can surprise people.
Definitely.
And then other drugs. Citrate, often from massive blood transfusions, cocaine, methadone, hydroxychloroquine. The variety is just astounding. Shows how many different pathways can lead to this electrical vulnerability. Moving beyond drugs, cardiac conditions themselves, myocardial ischemia and infarction, myocarditis, heart inflammation, marked bradycardia, stress cardiomyopathy, also known as Takotsubo.
The broken heart syndrome.
That's the one. Also endocrine disorders, hypothyroidism, hyperparathyroidism, pheochromocytoma, hyperaldosteronism, hormones impacting heart electricity, even certain intracranial disorders, subarachnoid hemorrhage, thalamic hematoma, stroke, encephalitis, head injury. Shows the brain-heart connection.
Okay.
And finally, nutritional disorders, anorexia nervosa, starvation, liquid protein diets, certain types of weight loss surgery like gastroplasty or ileonageojunal bypass, and celiac disease. This exhaustive list truly underscores that when thinking about QT prolongation, clinicians have to look way beyond just cardiac meds. Consider the whole patient.
That's an absolutely incredible list. Really drives home how interconnected everything is. A problem way over here can cause a serious issue in the heart's electrical system. So with that thorough understanding of the acquired forms, let's now turn to congenital long QT syndrome, LQTS, which you mentioned briefly. This is purely genetic, right? The problem is essentially built in from birth.
Yes, you're absolutely right. Congenital LQTS is a fascinating, often challenging condition caused by inherited mutations in those specific genes, coding for cardiac ion channels. Those tiny protein gates controlling the flow of potassium, sodium, calcium, fundamental for ventricular repolarization, the heart's reset phase. The diagnostic hallmark on an ECG is typically that prolonged corrected QT interval, the QTC over 440 milliseconds in men, 460 in women. And the symptoms, fainting to sudden cardiac arrest, are directly due to those episodes of torsades de pointe VT. While there are several genetic forms, the three most common, LQTS1, LQTS2, mainly potassium channels, and LQTS3, mainly sodium channel, account for roughly 90% of cases. Mutations affecting calcium channels have also been described.
Do these different genetic types have distinct triggers or presentations? Like, does knowing the specific gene type help predict what might set off an episode?
Yes, that's a key insight into congenital LQTS. The specific genotype can indeed profoundly influence the clinical presentation and the typical triggers for arrhythmias. Patients usually present during childhood or adolescence with syncope, fainting, or tragically, cardiac arrest. For LQTS1, events are very often exercise-induced, especially things like swimming or intense physical exertion.
Exercise-induced, okay.
For LQTS2, Events are commonly provoked by emotion or sudden auditory stimuli, an alarm clock, a phone ringing, a loud noise. Interestingly, these are also more frequent in the postpartum period for women.
Emotion or sound.
Yeah,
Fascinating.
in stark contrast, sudden death in LQTS3 tends to occur during sleep or while resting, making it particularly insidious, harder to predict without history and testing. Asymptomatic patients might only be discovered through family screening after a relative has an event, or sometimes just incidentally on a routine ECG. Highlights the importance of thorough evaluation and family history for unexplained fainting or long QTC.
And how helpful is genetic testing in these cases? Does it give definitive answers, or is it more about risk stratification?
Genotyping can be incredibly helpful. For family screening, it's invaluable identifying at-risk relatives before symptoms appear, allowing proactive management. It also provides crucial reassurance regarding the diagnosis for the patient and family, confirming the genetic cause. While it doesn't always perfectly predict the exact course or severity, correlations between genotype, risk assessment, and response to specific therapies are continually emerging from research. This helps tailor treatment plans, moving towards more personalized medicine in cardiology.
So, given these risks, what's the primary treatment approach? Beta blockers seem common, but are they enough for everyone with LQTS?
You're right, beta blockers are a cornerstone. For most patients with LQTS1 or LQTS2, adequate doses, particularly non-selective agents like nadolol and propranolol, offer significant protection. They stabilize the rhythm and blunt that adrenergic surge that often triggers events. However, there are markers of increased risk that might warrant more. A QTC interval over 500 milliseconds, female gender, a history of syncope or cardiac arrest before diagnosis. For those with recurrent syncope despite optimal beta blockers or a high-risk profile, an ICD merits strong consideration as a critical life-saving measure.
Makes sense.
And just like the acquired form, avoiding QT prolonging drugs is absolutely critical for all patients with LQTS. Even those who are genotype positive but have normal QT intervals, they still carry that underlying susceptibility.
Right, avoiding those triggers is key. Okay, next we have what sounds like the exact opposite, short QT syndrome. This must be incredibly rare given all the focus on long QT. It sounds almost counterintuitive. Why would a short QT be dangerous?
It is indeed quite rare, especially compared to LQTS. In short QT syndrome, the QTC interval is paradoxically dangerously short, typically less than 360 milliseconds, often strikingly less than 300. The genetic abnormality here causes a gain of function of certain potassium channels, or sometimes reduced inward depolarizing currents. Basically, repolarization, the recharging phase, happens far too quickly.
Too fast.
Way too fast. This rapid repolarization creates an electrically unstable environment, highly vulnerable to chaotic rhythms. This abnormality is associated with atrial fibrillation, but more dangerously with polymorphic VT and tragically sudden death. It really underscores that both extremes of the QT interval, too long or too short, can be life-threatening.
Then there's Brugada syndrome. This one sounds distinct with its very unique ECG pattern, almost like an electrical signature and specific triggers.
Brugada syndrome is another rare but profoundly important inherited arrhythmia syndrome. It's characterized by a very specific, often diagnostic ECG finding. This hallmark is greater than 0.2 millivolts of ST segment elevation, with a coved ST segment and a negative T wave in more than one anterior precordial lead, usually V1 to V3. A very recognizable pattern.
Coved ST elevation.
Exactly. Clinically, it presents with episodes of syncope or cardiac arrest due to polymorphic VT. Crucially, these events occur in the absence of underlying structural heart disease. That's a key distinction. The pump is fine, the wiring is faulty.
And when do these events typically occur for patients with Brugada? Is there a pattern?
What's particularly interesting about Brugada is the timing. Cardiac arrest often occurs during sleep, or it can be provoked by febrile illness like a high fever.
Fever is a trigger.
A strong trigger. Clinicians are taught to be highly suspicious if a patient with a Brugada pattern ECG gets a fever and becomes symptomatic. Males are also more commonly affected than females. Genetically, mutations involving cardiac sodium channels, particularly SCN5A, are found in about 25% of cases, which raises a diagnostic challenge. How do you definitively distinguish Brugada from other things that cause similar ST elevation?
That sounds incredibly challenging, yeah. So many common conditions can cause ST elevation. You'd need a very keen eye.
You're absolutely right. It's often very difficult to distinguish Brugada from similar ST elevation due to, say, left ventricular hypertrophy, pericarditis, MI, hypotassium, hypothermia, right bundle branch block, even ARVC. Furthermore, a fascinating and challenging aspect is that the characteristic ST elevation can actually wax and wane over time. It's not always there.
It comes and goes.
Exactly. It might only become pronounced during acute illness, especially fever. This variability makes diagnosis tricky. Interestingly, giving certain sodium channel blocking drugs like flecainide, agmeline, or procainamide can actually augment or unmask this ST elevation in affected individuals. It serves as a diagnostic tool, a sort of pharmacological stress test in suspected cases.
So once someone is diagnosed with Brugada, what's the recommended management? Given the serious risk, it must be quite aggressive.
The primary treatment, particularly for symptomatic patients, is indeed aggressive. An ICD is strongly indicated for individuals who've had unexplained syncope or survived a cardiac arrest. It's that crucial safety net.
Right, the ICD.
Beyond the ICD, specific drugs can help. Quinidine has shown some success, and catheter ablation of abnormal regions on the epicardial ischium, the outer surface of the right ventricular free wall, has also been used successfully to suppress frequent VT episodes in some patients. So it's a multimodal approach.
Moving now to early repolarization syndrome. Is this as serious as the others or more subtle? The name sounds almost benign.
Well, while the name might sound subtle, early repolarization syndrome is identified in a very specific and concerning group. Patients resuscitated from idiopathic VF ventricular fibrillation with no structural heart disease or other identified cause. These patients show a higher prevalence of J-point elevation with notching in the terminal QRS on their ECG. That J-point is the junction between the QRS and ST segment.
J-point elevation with a notch.
Yes. A family history of sudden death is present in some, suggesting a genetic basis, though the specific genes are still being worked out. Interestingly, J-point elevation is also seen in some Brugada patients and is associated with higher arrhythmia risk there too. For those who've had a prior cardiac arrest due to this syndrome, an ICD is recommended given the high recurrence risk. But this raises a crucial question. Is any J-point elevation always a sign of this syndrome?
Right. So what does this mean for someone who just shows J-point elevation on a routine ECG with no symptoms or history? Should they worry?
That's a vital distinction. It's critical to note that J-point elevation is in fact commonly seen as a normal variant in healthy people with no arrhythmias or symptoms. In the absence of specific symptoms like syncope or prior arrest, its clinical relevance isn't known to be problematic. It doesn't automatically mean someone has this dangerous syndrome. It absolutely requires careful clinical correlation, considering the full medical history, family history, other evaluations before raising concern. A classic example of interpreting ECG findings in context.
Got it. Okay, next, a very descriptive name. Catecholaminergic polymorphic VT. The name itself suggests a direct link to stress hormones. What's behind this rare familial syndrome?
Catecholaminergic polymorphic VT, or CPVT, is indeed rare but highly dangerous. It's caused by specific mutations, primarily in the cardiac ryanodine receptor, RIR2, and less commonly in calsequestrin 2. Now, these proteins are involved in handling calcium within the heart cells, specifically within the sarcoplasmic reticulum, which stores and releases calcium for contraction.
Calcium aniline.
Exactly. These mutations result in abnormal sarcoplasmic calcium handling. This leads to polymorphic ventricular arrhythmias that strikingly resemble those seen with digitalis toxicity, another condition known to mess with calcium. And the catecholaminergic part, that directly refers to the critical role of adrenaline and other stress hormones, catecholamines, in triggering these arrhythmias.
And what's unique about the arrhythmia itself in CPVT, are there specific ECG patterns?
Yes, a key diagnostic clue is the unique morphology of the VT. It's either truly polymorphic, with that constantly changing shape, or it has a very characteristic alternating QRS morphology, specifically termed bidirectional VT.
Bidirectional VT?
Yes, where the QRS complex is literally alternate direction from beat to beat. Seeing that is highly suggestive and should immediately raise suspicion for CPVT. Patients usually present during childhood or adolescence with palpitations, syncope, or even cardiac arrest. Crucially, these events are almost always induced by exercise or strong emotion, precisely when the body releases those stress hormones, overwhelming the faulty calcium handling system.
How is this challenging syndrome managed then? Seems like a delicate balance.
Management requires a multi-pronged approach. Bolt adrenergic blockers, like nadolol and propranolol, are usually first line. They reduce the adrenergic drive, blunting the heart's response to stress hormones, trying to prevent that abnormal calcium release.
Beta blockers first.
Yes. Given the very high risk of sudden death, an ICD is also typically recommended as that critical backup. Beyond these, other agents like verapamil, a calcium channel blocker, Or flecainide, a sodium channel blocker, can help. In some refractory cases, surgical left cardiac sympathetic denervation, cutting nerves, carrying stress signals to the heart, can also reduce recurrent VT. However, this raises a crucial subtle point. Can the ICD itself pose a unique challenge in CPVT?
You're saying the device meant to save a life could potentially cause a problem? That sounds like a significant nuance.
Potentially, yes. This is a critical subtlety. In some patients, especially those very sensitive to adrenaline surges, the ICD shock itself, while life-saving at that moment, can trigger a massive release of the body's own adrenaline.
A shock-induced adrenaline rush.
Exactly. This surge can then provoke further, escalated ventricular arrhythmias, potentially leading to a cascade of painful shocks and a rhythmic storm, and tragically, even death in extreme cases. This highlights the absolute necessity of optimizing beta blocker therapy and considering other treatments to prevent the need for ICD shocks in the first place. Minimize that proarrhythmic risk. It's complex decision-making.
Let's move on to hypertrophic cardiomyopathy, HCM. This is actually a relatively common genetic disorder and a major cause of sudden death, particularly in younger people. It gets a lot of attention.
HCM is indeed very important. A key insight is its prevalence. About 1 in 500 individuals makes it the most common genetic cardiovascular disorder. And yes, it's a prominent cause of sudden death, especially before age 35, often tragically affecting young athletes. The sudden death can be directly attributed to polymorphic VT or VF. More rarely, sustained monomorphic VT can occur, usually related to areas of scar, particularly in patients who develop an apical aneurysm, a weakened, bulging area at the heart's apex. The disease itself is characterized by unexplained thickening of the heart muscle, often asymmetrical, without an obvious cause like high blood pressure.
So, given its prevalence and serious risk, what are the key risk factors for sudden death in HCM? How do clinicians identify those at highest risk?
Identifying high-risk individuals is paramount. Key risk factors include young age at presentation, documented non-sustained VT on monitoring, failure of blood pressure to increase normally during exercise, a recent history of syncope within 6 months, significant ventricular wall thickness, usually greater than 3 centimeters, and possibly the severity of left ventricular outflow tract obstruction, though its independent role is debated. These factors, alone or together, guide a complex risk stratification to decide who might benefit most from preventive therapies like an ICD.
Given these risks, is an ICD always the answer for high-risk individuals with HCM, or is it still debated? Different treatment philosophies, maybe?
The role of the ICD is nuanced. It's generally indicated for high-risk subjects, but the precise risk profile warranting one is still debated, with ongoing research refining guidelines and risk calculators. What's also important is managing the outflow obstruction many HCM patients have. Surgical myectomy removing some thickened muscle has been associated with a remarkably low sudden death rate, less than 1% per year in experienced centers. It seems to reduce mechanical and electrical strain.
That's very low.
It is. However, the reported annual rate of sustained VT, or sudden death, after transcoronary ethanol septal ablation, another procedure using alcohol to create a small infarct and reduce muscle bulk, has ranged between 1% and 5%.
Higher than surgery.
Generally reported as higher, yes. So different risk-benefit profiles depending on the intervention chosen to manage the underlying HCM, with surgery often showing superior long-term outcomes for sudden death risk reduction.
Finally, in this genetic section, let's talk about genetic dilated cardiomyopathies. How do these relate to arrhythmias, and what's the typical presentation?
Right. Genetic dilated cardiomyopathies account for a significant portion, maybe 30% to 40% of non-ischemic dilated cardiomyopathies, meaning not caused by coronary blockages. Some are also associated with muscular dystrophy, highlighting a broader systemic connection affecting both skeletal and cardiac muscle. Recognized inheritance patterns are diverse: autosomal dominant, recessive, X-linked, mitochondrial. A critical insight is that mutations in genes coding for structural proteins of the nuclear lamina, like lamin AC and the SCN5A gene, that sodium channel gene again, are particularly associated with both conduction system disease problems with the heart's wiring and a heightened risk of ventricular arrhythmias.
So what kind of arrhythmias do we typically see, and how are they managed given the compromised heart function?
Patients can experience a range of dangerous arrhythmias, polymorphic VT and cardiac arrest, or they can develop scar areas leading to sustained monomorphic VT. For management, ICDs are key, recommended for those who've had a sustained VT, secondary prevention. Also indicated for patients at high risk due to significantly depressed ventricular function, that ejection fraction less than 35% plus heart failure symptoms, or those with a malignant family history of sudden death, suggesting a particularly aggressive genetic predisposition. These genetic mutations often necessitate a more proactive approach.
Okay, let's shift our focus now fully to ventricular fibrillation, or VF. We've heard repeatedly that PVT often degenerates into it, underscoring its extreme danger. What exactly is VF on an ECG, and why is it so incredibly dangerous, immediately life-threatening?
VF is the ultimate electrical chaos in the heart, completely disordered electrical ventricular activation. On an ECG, there are no identifiable QRS complexes, no organized contractions, just chaotic, irregular electrical signals, often described as looking like a bag of worms.
Bag of worms.
It is. Physiologically, imagine multiple, uncoordinated electrical impulses firing randomly within the ventricles, preventing any organized pumping action. Mechanistically, it likely involves multiple spiral wave reentries, numerous circulating reentry wavefronts, essentially an electrical storm where no effective contraction can happen. Its clinical relevance cannot be overstated. Sustained polymorphic or monomorphic VT degenerating to VF is a common cause of out-of-hospital cardiac arrest. Leads to immediate collapse, loss of consciousness, and if not treated within minutes, irreversible brain damage and death. It's the most dire cardiac emergency.
So given it's such a critical emergency demanding immediate action, how is VF managed right away? What's the protocol?
Treatment rigorously follows ACLS guidelines, standardized protocols for cardiac emergencies. The absolute cornerstone is immediate defibrillation.
The shock.
The shock. Delivering a controlled electrical current across the chest to reset that chaotic activity, allowing the heart's natural pacemaker, hopefully, to regain control. Time is absolutely critical. Every minute of delay drastically reduces survival chances. If resuscitation is successful, then a comprehensive evaluation follows to identify and treat any underlying heart disease and potential causes. Looking for MI, or checking if VT triggered the VF. If no transient reversible cause like an acute MI is found, then long-term therapy with an ICD is often warranted. The risk of recurrence is just too high. The source also points to Figure 255-2 showing fascicular ectopi triggering VF, especially after an MI. What does that figure help us understand about the subtle underlying mechanisms? Yeah, Figure 255-2 offers a fascinating insight into the role of Purkinje fibers in initiating VF post-MI. These specialized conduction fibers often survive an acute infarct. Why? They have greater glycogen stores, their internal energy reserve, and they get better oxygenation directly from the blood inside the left ventricle, unlike muscle relying solely on coronary arteries.
So they survive better.
They can. But here's the crucial point. Upon revascularization, when blood flow is restored, these surviving but often poorly coupled Purkinje fibers can become irritable. They can spontaneously trigger PVCs. And these PVCs, especially if they fall during that vulnerable period, R on T, can in turn initiate ventricular fibrillation.
So the survivors become triggers.
Exactly. It highlights how even parts of the electrical system that survive damage can become problematic, acting as persistent triggers for life-threatening arrhythmias. Creates a very delicate electrical environment after an MI.
Let's shift our gaze now towards the future. The source outlines some really promising new directions for treating ventricular arrhythmias. First, for monomorphic VT, what are the current limitations that these new approaches are trying to tackle? What challenges remain?
Right. In managing monomorphic VT, especially with structural heart disease, current therapies do face significant limitations. These include potential toxicities from long-term antiarrhythmic drug use side effects impacting quality of life, posing risks. Another major limitation is the inability to successfully perform catheter ablation of the underlying arrhythmia substrate in all patients, which raises the question, why is ablation sometimes unsuccessful? What are the challenges?
Is it just hard to get the energy to the exact right spot? A precision problem deep inside the heart muscle?
That's certainly part of it. A significant limitation is the inability of conventional ablation energy to consistently reach deep intramural substrates. The source might be deep within the heart wall, beyond the reach of standard catheters delivering energy mainly to the inner surface.
Too deep to reach easily.
Often, yes. What's fascinating here is the ongoing innovation in delivering ablative energy specifically to overcome this depth limitation. Techniques like bipolar ablation, using 2 electrodes for deeper energy delivery, needle catheter ablation, allowing direct, deeper penetration, and electroporation, a novel technique using electrical pulses to create pores in cell membranes, causing cell death without heat.
Electroporation.
Interesting. Very. These innovations aim to improve success rates by reaching those previously inaccessible arrhythmia drivers.
And then there's this particularly exciting area, non-invasive ablation. Sounds like science fiction. Treating the heart without any incisions.
It's a truly revolutionary and rapidly developing area. Non-invasive ablation uses highly targeted energy, specifically proton beam therapy or stereotactic body radiation therapy, SBRT. Technology is often used in cancer treatment to ablate VTs.
Radiation therapy for arrhythmias.
Exactly. The precision is remarkable. The VTs are identified with extreme accuracy using advanced cardiac imaging like MRI or CT, sometimes even a multi-electrode ECG vest mapping electrical activity on the body's surface to pinpoint the source. Early multicenter studies are already suggesting durable VT control with this non-invasive approach. It's a potential game changer, minimizing invasive procedures and risks, improving safety and recovery.
Truly groundbreaking. Can you walk us through figure 254-5, which illustrates stereotactic body radiation therapy? What's involved in that whole process, from planning to delivery?
Sure. As depicted in figure 254-5, the process is meticulously planned. It starts with a high-resolution planning CT scan. The region of interest, the precise target area, is then determined with incredible precision. This involves analyzing the patient's specific arrhythmias, their underlying structural heart disease, often scar tissue, and crucially, the proximity to adjacent vital structures. Which raises the question for the team. Why is proximity to other non-cardiac structures so critical?
I imagine you absolutely have to avoid hitting anything else nearby. Lungs, esophagus, major vessels.
It's exactly right. Paramount consideration is given to protecting surrounding healthy structures. Coronary arteries, the phrenic nerve controlling breathing, the GI tract. The goal is absolute precision, avoiding collateral damage. Once the target volume is precisely defined, the radiation is delivered, often in a single high dose, aiming to create a conduction block in that culprit scar region, effectively neutralizing the arrhythmia source without a single incision. It's a remarkable feat of engineering and medical science.
Moving to future directions specifically for polymorphic VT and VF, is there an evolving role for catheter ablation here too? Beyond the more organized monomorphic VT, ablating chaos sounds incredibly difficult.
That's a perceptive point. Yes, the role for catheter ablation in polymorphic VT and VF is rapidly evolving, despite the challenges of targeting chaos. Some investigators are using innovative tools like basket catheters with multiple electrodes mapping a larger 3D area simultaneously to meticulously define critical sites for arrhythmia initiation or propagation.
Mapping the chaos.
Trying to, yes. They're also correlating these detailed electrical maps with advanced cardiac imaging, MRI, CT, to precisely identify typical vulnerable sites for ablation. This moves beyond just finding the immediate trigger to understanding and targeting the underlying anatomical and functional substrate that allows the chaos to propagate, aiming for more durable results.
Before we wrap up future directions, let's just briefly revisit the existing state of catheter ablation for monomorphic VT. What are its current success rates and limitations in practice today?
Sure. For symptomatic monomorphic VT, catheter ablation, primarily for symptom control, boasts an overall success rate around 80%. It's recommended for those with symptomatic VT where drugs are ineffective, not tolerated, or not preferred. What's insightful is that efficacy and risks vary with the VT origin site. It's most favorable for arrhythmias from the right ventricular outflow tract, often more accessible, more defined substrate. However, a common challenge, a significant limitation, is failure often stems from inability to initiate the arrhythmia for mapping in the lab. If the VT isn't happening or can't be induced during the procedure, it's incredibly hard to find and target the source, like fixing a flickering light when it's not flickering.
Right, hard to target what you can't see. And finally, just a quick mention of left ventricular intervesicular VT from the source. How is that managed? Ablation's role there.
Right left ventricular intervesicular VT is a specific idiopathic form. It can often be terminated acutely with intravenous verapamil, that calcium channel blocker. Often works well immediately. However, chronic therapy with oral verapamil isn't always effective long-term. In such cases, catheter ablation is recommended if beta blockers or oral calcium channel blockers are ineffective or not desired. So ablation is a crucial, often definitive alternative for this specific VT type if meds don't cut it long-term, offers a highly effective solution.
Wow, what an absolutely incredible journey we've taken through the complex, often chaotic, yet deeply fascinating world of polymorphic ventricular tachycardia and ventricular fibrillation. We've unpacked everything from their fundamental definitions, the subtle nuances of their electrical mechanisms, to the huge range of causes: heart attacks, genetic mutations, surprising medications, even nutritional issues. We've explored the cutting-edge treatments transforming lives, from immediate defibrillation to the exciting future with things like non-invasive ablation, really pushing the boundaries.
In the broader context, what truly stands out is that intricate, often unpredictable interplay of genetics, environment, specific cardiac conditions. all determining susceptibility and response. Mastery in this field, as we've tried to explore today, means more than just knowing definitions. It's understanding the subtle distinctions, the critical interconnections, and the constant evolution of diagnostics and therapeutics. It's about building that comprehensive mental model.
So what does this all mean for you, the listener? Whether you're prepping for a high-stakes medical meeting, maybe catching up on a complex field, or you're just insanely curious about how the body works, we hope this deep dive gave you that aha moment. We really aim to make you feel truly well-informed, equipped with an elite-level understanding without the information overload of tackling Chapter 255 completely on your own.
And as you reflect on this journey through the heart's electrical complexities, maybe consider this. What else might we uncover when we connect seemingly disparate pieces of information? Not just in cardiology, but in any field we want to master. Keep asking those deep questions. Keep exploring the intricate connections that reveal true insight.